Good afternoon, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. I'm joined today by Belén Lawless, who's one of our neurologists new to the Good Samaritan family. We'll be talking a little bit about her practice, her background and training, where you grew up, some of those things, and then also talk a little bit about historically what all has happened in neurology, and then some of the things that you enjoy in practice. So welcome.
Well, thank you for having me.
So tell me a little bit about your background, where you grew up, a little bit about your training, history, those types of things.
Well, so I was originally born in Argentina, Buenos Aires, and we moved around a lot my whole life, but we grew up mostly in Ohio, in Akron, and so the States kind of always was home, even though we moved out of the States, but not back to Argentina. And then I went to college at Loyola University in Chicago, and that's where I met my husband. But then I was in business school, wasn't sure really what I wanted to do, and during that time is when I had this epiphany, decided I wanted to do medicine. So then after that, I took a couple years to get ready for medical school and apply and do all that, do more pre-med things, and then I got into University of Illinois in Urbana-Champaign, that campus. There's a Chicago campus and then one in Peoria as well. And I went there, and then I went to Peoria for the next 3 years. And then I really enjoyed my time there, and my husband's from Alny, Illinois, so we wanted to stay around that area, so I did my residency there as well.
Well, that's fantastic.
Yes.
So take us back a little bit. You had mentioned that you kind of started off in the business world, thinking business, and then got sucked into medicine. So tell us about that transition.
Well, so my dad worked for Goodyear, and he, was always very impressed by, he would go to work and have the suitcase, and I kind of want to do the same thing. I'm kind of more creative mind more than he's more analytical. But so I want to do marketing, I thought. So I was in business school for a couple of years, and I just wasn't resonating with me, but I still, what I signed up to do, I was doing it. And one day but I also liked the sciences a lot. I was still taking, biology and chemistry just because I liked the sciences. And I was in a childhood psychopathology class, and we were watching a video on kids that had Tourette's and autism. And I mean, it was just one of those moments in your life. I still remember that day. I was sitting there and I was listening to these kids talk about how hard it was for them to have these tics, and they would get made fun of at school. And the longer they tried to hold them in, then the worse it was when they finally came out. And it was just, it was just so hard to watch that. And I was crying. And then on the other side, the autism side with the mothers because they used to tell these mothers that had autistic kids that it was their fault. Right. They would call them the refrigerator mothers. And so it was just, and these mothers were like, I've done, everything for my kids. I don't know why they're like this. I don't know what to do. And then to go to the doctor who's supposed to be, on your side, right? And they would just tell them, it's your fault. And then, now we know better, right? But back then they didn't. And so I was just bawling. I was so moved by that. And I said, I don't like business. I don't like my classes. If I could do something and help one of these kids or one of these mothers or something, change someone's life, it would make my life so much better. I would love to have that job where I could do that. So that was the moment. I said, okay, well, I'm quitting. I quit business school, and then I just started looking up what I had to do to get into medical school. And we don't have a lot of medical background in my family. My aunt in Argentina is an internal medicine doctor, but here in the States, so it was kind of rough for me for a little bit to do that transition because I had already spent so much time in business school, and you have your pre-med requisites and all this stuff. So it was it took me some time to get to that point where I could go into medical school, but that's what I did. I worked hard, and here I am.
And so initially, it sounds like you were kind of already initially, even going into med school, drawn to neurology, neurological processes, so forth. Tell us a little bit more about what that transition was from going from medical school and then saying, okay, I've got all these potential opportunities. I'm going to specialize in neurology.
Well, you're right. So one of the things that drew me very early on was psychology, and that's why I was taking the childhood psychopathology, and the way the brain works and how that manifests, and especially, one of the things in more existential kind of way, like the mind and who are we and how are we, and we have this physical brain, but then we have this mind. And so that was always very fascinating to me, and that's what started kind of drawing me into that realm. And then I just became more and more appreciative of the brain. And in medical school, I actually did like a lot of the different specialties, but neurology was the one thing I couldn't get enough of. I just was so interested in it. It was, to me, is fascinating, and it still is fascinating. And so that was, and then, on top of that too, my aunt, she had MS. And so that also kind of opened, the doors to neurology kind of early on in terms of trying to understand her illness and what she was going through. And that's one of the diseases that we still are, we have better medications these days, but, in terms of, making a lot of headway, we're still, we're not there yet, so.
Sure. And, going back, I trained in Chicago. It's been 24 years ago or so. And I distinctly remember not choosing neurology at that time because my perception was I was going to diagnose these people with something that we knew nothing about and we could do nothing with. But fortunately, really, medicine has changed a lot in the past 10 to 20 years in terms of becoming more evidence-based. And a lot of the areas that we've struggled with, really we've learned a lot more with, and the medications and modalities of treatment have changed dramatically too. So just, in general, in the realm of neurology, what are the areas that you tend to enjoy the most as far as what patient types, what disease processes, those types of things?
I think for me, so I had a personal tie to this in the beginning. My son had a febrile seizure when he was just 2 years old, and that kind of sparked my interest in epilepsy. But then, in addition to that, when in my training, when we would have people that would come in with very bad seizures or status epilepticus, and then that's something you can actively do something about, and you see the change. And so that always something that that really got me interested in and so I actually wanted to do a fellowship in epilepsy, but due to family circumstances, we're not doing that anymore. But that's something that I'm still very passionate about and something that is still interesting to me. One of those areas that you can make a huge difference for patients that are having, multiple seizures a day. When you can actually get those controlled and it changes their life, it makes it makes a big difference. It's really nice. You feel it's very rewarding.
Sure. And I think that has always been the challenge for me with neurology is that I've felt powerless to do things. But like I said, nowadays, the imaging modalities that we have, the treatment modalities that we have, just the diagnostic options that we have are so much better than what they were even a few years ago. And seizure disorder is surprisingly common. I practice family medicine, and seizure disorder is common in our practice, dating just with our pediatric population where febrile seizures are extremely common. And I think a lot of the importance from a diagnostic standpoint is accuracy of initial diagnosis. That's certainly a big challenge that we have. People will witness events of seizure or presumed seizure. We have plenty of patients that come to us that are diagnosed with seizure that had tonic-clonic activity associated with vasovagal spells.
That's right.
And so I think one of the really great benefits to having neurology involved is really getting that good initial first diagnosis. And so we are excited to have you here and practicing within our Good Samaritan family because access to patients is challenging. Whether it is neurology or nephrology or rheumatology, the specialist areas of medicine are challenging because access to our local population is limited. So we're excited that you're here and excited that you're able to provide these services to our patients. Now, one big thing that we've certainly got to hit on is upcoming month of May is Stroke Awareness Month. And certainly one of the even more common neurological things that I see in my practice and certainly that you will help us with is stroke. And so as with just about any disease process, one of the things that we really prefer is to prevent diseases from happening in the first place. Yes. Anything that you can talk to our population about as far as stroke prevention? Obviously, we know and we can talk about medications and things like that once you've had it, but really as far as stroke prevention.
Yes. So, it's one of those things where I feel like we tell people don't smoke, eat right, eat your vegetables, your fruits, and it's all easier said than done. And at this point, back in the day, people didn't know that cigarettes were bad for you, right?
Yep.
They didn't know. Nowadays, it'd be very hard, I'd be hard pressed to find someone, I think, that really didn't know that cigarettes were bad. But then knowing that and then quitting is a different story, right? And
Absolutely.
so the truth is that what is good for your heart, cardiovascular health, but for your just in general well-being is those are the things that are preventative for stroke. So, just trying to live a healthy lifestyle. And I guess the main thing is everybody's different. And so I think the key is to not say, okay, well, one day I'm going to just quit smoking, or I'm going to eat only salads, or I'm going, that's not how it works, because these things are ingrained in our lifestyle, right? How we eat, when we eat, what we eat, all that stuff is part of who we are. And so changing that is really, it's not something that, that's why those fad diets and things like that, they don't ever work. And that's why they make so much money, because, people fail one diet, then they go to the next one, and it never works, because you can't change who you are in a day. And you can't change who you are in a week. And so I think first of all, for anyone, that has these risk factors, be it high blood pressure, diabetes, high cholesterol, things like that, is first gain that awareness that you have a risk factor. And even people that don't have these, these are things that you can develop. A lot of people will develop these things in their lifetime. And so what can I do to help mitigate that risk? And so first is being aware and deciding, hey, I don't want that. Stroke is interesting because, unlike heart attacks and things like that, most people, well, I don't want to say most people, but people can have a significant heart attack and then walk out of there.
Absolutely.
With stroke, if you have a severe stroke, you could have severe disability for the rest of your life. You may not be able to eat, walk, take care of yourself, and you may survive the incident, but then the disability is really what is, the hard part about stroke. And so that's why it's so important to really be active about your prevention of stroke, and especially if you have any of those risk factors. And so I think people need to first be aware, and then be aware that change is a process. And so to have those goals for yourself and just work towards them, instead of saying, okay, I'm only going to eat salads. No, start incorporating salads into your meals, start incorporating vegetables. Don't try to change everything overnight. So baby steps, same with like activity, you're not going to go to the gym. It's not sustainable to say, okay, I'm going to wake up at 5:30 from now on every day and go to the gym for 30 minutes. And it's like, how long are you going to do that before you're right back to your old routine? So it's about really, baby steps and doing what fits into your life. If you can't get up at 5:30, then trying to make yourself get up at 5:30 isn't going to work. Where do you look at your days? Where do you have time? Look at actually, and that's the process towards making change and getting healthier, is look at your life, look at your schedule, look at what is who you are, and where can you make these changes, and then start making them slowly, and over time. That's the beauty about habit. You start making change, you do it long enough, and it's no longer change. Now you're there, right? So and that's another thing that I really love about medicine is working with people and finding what's best for them. And so that's what I would say. I'd say I think most people have areas in their lives where they could make some of those changes and just go ahead and do it, but do it in the way that's right for you.
Well, and I think you touched on some really important factors, which are the risk factors for stroke. And a lot of times people don't understand that stroke is something that's preventable, that when we look at family history, when we look at blood pressure, when we look at diabetes, when we look at cholesterol levels, when we look at all those factors, those are the things that add up to stroke. Mm-hmm. It's not that you just walk in, you have this one thing, and you get a stroke. I tell people it's like making concrete. You can't make it with water. You can't make it with water and sand. You can't make it with water and sand and gravel. It has to be water, sand, gravel, and concrete. So all of those things go together. And when we talk about the cardiovascular diseases and vascular disease in general, all of those factors come into play. the thing that you led with is so terribly important, which is smoking. And unfortunately, in the Midwest, smoking is still very predominant. And so we do a lot of education on that. The other things that our patient population sometimes doesn't understand is that getting screened for those other things, getting screened for high blood pressure, getting screened for diabetes, getting screened for cholesterol is very important, because almost all of those things we just listed have no symptoms. Most people have no symptoms with high blood pressure. They have no symptoms with high cholesterol. They have no symptoms with initial diabetes. And they may know that they have a family member that had a stroke or had a heart attack. They may not necessarily know what age they were, but it's important to take into account those family risk factors and then make sure that you get screened at a reasonable age. Because getting screened for diabetes, high blood pressure, and cholesterol for the first time at 65 isn't nearly as important as when you are becoming an adult, when you're an early teen, when you're going into college age or work age, to make sure you get those things done. Through here at the hospital, we have multiple episodes throughout the year where we do screenings, specifically wellness for men, wellness for women, and opportunities for people to get those screenings done essentially locally for free. Thankfully, nowadays, workplaces and insurance companies cover most of those screening things for free, and encourage patients to stay in touch with primary care and also to get those initial screenings done as a prevention. And so, obviously, when we have any month that comes along, whether it's heart attack, stroke, skin cancer, so forth, that's kind of our opportunity to get that word out to the public and work on that. The other thing that I think sometimes gets glossed over is how important time is when it comes to stroke symptoms. Would you speak a little bit about how that works? Because our population here in the Midwest is kind of tough, and they sort of like to wait things out. And sometimes they stay home and they just want to see how things are going to play out. And with some disease processes, diverticulitis, things like that, it's okay to wait a little bit and see what's happening. But with stroke, that's generally not the case.
Yes. So time is neurons, we like to say. So as soon as you yourself are experiencing anything kind of out of the ordinary, especially something that would be weakness on one side of the body, facial droop on the one in the lower half of the face, any visual deficits, acute onset confusion as well. Sometimes sometimes it's just confusion, dizziness, anything that is a symptom that you are experiencing that comes on fast and is new to you. That already should be a red flag, and that's same for anybody that you're witnessing having symptoms like that, and immediately call 911. The thing about stroke and going to the hospital, well, if it turns out to not be a stroke, then fine. But if it is a stroke, then time is so important, because the interventions that we have are very time dependent. And so for example, TPA is a medication, is the clot busting medication, and as you know, we only have 4.5 hours to give that to somebody. Well, that may be changing here in the future,
sure.
But just for simplicity's sake, right now, that would be, we have 4.5 hours to administer that medication, and there's 1 in 3 chance that you're going to do better if you get that medication. So it's very important for people to come in within that window. If you wait, you may miss that opportunity. In addition, any surgical interventions that may be done, that's also, if you're waiting too long, then the damage might be too severe. If you need some pressure to be removed, if you need a hemicraniectomy or something like that, where they take part of your skull to relieve some of the pressure, if you have a hemorrhagic stroke where there's bleeding that's causing the stroke, the longer you wait, the more damage there is. And so, as I said, just in general, time are neurons. Time is brain, is what we like to say. And so it's of utmost importance that at any time that anyone suspects stroke, be it for yourself or somebody else, you call 911 and you get to the hospital immediately.
One of the other things that I get frequently asked, and I think I get frequently asked it because this has changed several times over the last 15 to 20 years, is aspirin therapy. So I'm a 50-year-old male now, and should I take a baby aspirin every day for heart attack or stroke prevention? And the answer is no. And that's very different from what we were telling people 20 years ago. And interestingly, what we tell men and women sometimes differs a little bit. Can you talk a little bit about that?
Well, I think it's like you said with the evidence base, right? So as we are collecting more and more data, we are starting to see, to really see how things play out. And that's part of the issue too, is we need enough data and enough time sometimes to see how things add up. And so with the aspirin a day, that was, and that's kind of intuitive, right? Oh,
Yeah.
That's what we tell people, what we give people after they've had the stroke. So, okay, so take your aspirin a day. But then what turned out is most people are having the bleeding and the issues from the GI issues and the bleeding from the aspirin a day. That ended up being worse than the actual supposed preventative benefit we were getting. So that's changed. So now, but a lot of people, without even their doctor telling them, I've noticed, still take an aspirin a day because that's what they heard. And so I think that's a very good point that you brought up, because I think that's something that we do need to educate people on is don't please, unless you consult with your physician, don't take an aspirin a day. Don't take any medications really without consulting with your physician, because some of these things are, that kind of knowledge, unfortunately, it hasn't been, I think, promoted enough. And so I seriously encounter so many people that are still, I'm taking my aspirin,
right.
and it's like, oh no, wait, but don't do that, please.
And I think one of the challenges with that is within our patient population, and sometimes even within our physician colleague population, primary prevention versus secondary prevention gets kind of muddled together. And so, a lot of times in my practice, when I see that the nurses have put on their list that they're taking a baby aspirin, one of my first questions to the patient is, well, why do you take baby aspirin? And if that answer is, I've had a heart attack before, I've had a stroke before, I have this clotting disorder, then that's a very different conversation than what you and I were just having, which is, I take a baby aspirin because it's a good idea to take a baby aspirin to prevent a heart attack or stroke. So it's important that our patient population understands that if you have high blood pressure, you have pre-existing cardiovascular disease, you have other types of vascular disease, that your provider has likely told you need to be on those medications for a specific reason, versus saying, I'm going to preventively take this to prevent that for the first time. And similar things are true when we talk about cholesterol type medications and blood pressure medicines and so forth. So May is Stroke Awareness Month. Now, neurology is a very broad category of medicine. So can you tell us a little bit about what other disease processes besides just stroke or vascular problems and then seizure problems people in neurology treat? So
we are also dementia specialists, and as the population keeps getting older and older, we live longer and longer, that's becoming more and more prevalent. And actually, there's a higher incidence of dementia in rural communities, which there's a lot of speculation about that, but part of that concerning with the chemicals that are being used in farming communities. But dementia is at higher rates in rural communities, and that's something that we definitely see patients for. In addition, movement disorders. So a lot of people think Parkinson's is dementia, but Parkinson's is not technically dementia. You can have dementia with Parkinson's, but that's what we would consider a movement disorder. And that's defined by rigidity and bradykinesia, which means slow movements. That's another thing that people tend to think about tremor or shaking with Parkinson's, but that's actually not part of the defining characteristics of Parkinson's. So there's other movement disorders as well. There's what we call dyskinesias, and tics, things like that. In addition, headaches. We're headache specialists. So a lot of times migraine is a very common headache, and it's also a very commonly misdiagnosed headache, same as tension headaches. And so a lot of times people come in and they're like, oh, this isn't working for me. Well, they weren't correctly diagnosed in the first place.
And people sometimes ask, too, about, obviously, central nervous versus peripheral neurological problems. Are there things that you deal with at neurology from a peripheral standpoint?
Yeah, so, peripheral neuropathies, a lot of times people that how diabetes is so prevalent, we see a lot of patients that are coming in with symptoms like that for that. And I mean, really any diseases of the nerves themselves or the muscles even themselves we'll see. So a lot of people that have weakness and then determining where that is coming from. And yeah.
And then any particular things that you do procedurally as far as things within neurology?
Well, so I do want to kind of build up. I haven't started my practice yet, but when I do, one of the things I'm looking into is doing Botox for migraine. Botox is the only FDA-approved medication for chronic migraine. So I want to get that started in my clinic. Also do some nerve blocks. So sometimes you can have headaches due to specific nerves
Absolutely.
kind of acting up. So we'll do some nerve blocks. And then I'll be doing some EEG reading. And in addition to that, I'll be doing my own lumbar punctures, which that'll be mostly inpatient, but we can do those also as an outpatient as well for certain diseases. So those are the main things. Oh, Botox can also be used for other conditions such as like dystonia when you have, certain, contractures, things like that. But I'm going to look into seeing if I want to integrate that. So we'll see, kind of baby steps with that.
Well, and I think that's, again, one of those medications that now has found its place in medicine all over the place. We do Botox for cosmetic and aesthetic reasons over in our aesthetic practice, but thankfully, individuals like yourself are utilizing that to have a tremendous impact on people, specifically with some of these headache syndromes, and with great success and with very little side effects.
Yes.
I think a lot of times when we talk to patients about Botox and things like that, their first response is, Botox, could we not come up with a better name than toxin?
Yeah.
But the fact of the matter is, very safe, very predictable, very few side effects, and that's rare in the medicines that we used to treat our populations with. Nearly all of them have some horrible side effect that is competing with the disease for how severe it is.
True. Exactly.
So very exciting that you'll be offering that service, because I think patients that have been in other locations have really seen and benefited from that with very minimal side effects. So a little bit about where your practice is. Can you describe where you're going to be practicing, a little bit about times, those types of things as far as your office is concerned?
So my office is in the hospital, and I'm still relatively new, so I don't know exactly where that would be in the hospital. But
Health Pavilion.
Okay, on the third floor. And as of right now, I'll be doing Monday through Thursdays, kind of longer days. But as I practice, we'll see if we make any adjustments. But that's the plan right now. So.
Excellent, exciting. And are there particular things that you're sort of local around here? You and I are both Illinois folks, so thankfully we're on this side of the river as far as practice of medicine is concerned. But can you tell us a little bit about things that you like to do?
So the main thing is spend time with my family. I love my family. I have 2 young kids. But I'm a very outdoorsy person, so I love being outdoors. Anything that has to do with outdoors, I'm all about it. So I picked up golf a couple. Well, it's been,
Sorry to hear that.
No, it's a love-hate relationship, isn't it? But so I love playing golf and tennis, and I can't wait till my kids are a little older so that I can start involving them in these activities as well. But I also have 2 dogs. So we like to go on hikes, and we just got some chickens and some ducks. So
absolutely
learning about that, and then soon hopefully we'll get some farming done. But with the weather, it hasn't been great for that. But yeah, basically, and then I like sports and reading and things like that too.
Well, that is super exciting. Any other things you'd like to discuss before we go to the phones and see if anybody has any questions?
I don't think so.
All right. Yeah. All right. To the public, what do we have as far as questions today?
Okay, we've got one so far. What is your experience with the geriatric population with regards to assessment regarding cognitive decline and cognitive testing for dementia?
So dementia, I was actually talking to Dr. Stein about this. Dementia is one of those more challenging diagnoses for us as neurologists, because a lot of dementias at first may kind of overlap, and then it really takes time to kind of tease it out and see what kind of dementia we're dealing with. And so anytime really, and what differentiates cognitive impairment from dementia is if people can do their what we call activities of daily living, right? So are you still able to go to the store and buy your things? Are you still balancing your checkbook? Are you still dressing yourself, feeding yourself? And when those things are starting to get effective, that's when we start getting into that demential realm. And the other thing that's also, with as time goes on and we have more evidence, another question is, when does cognitive impairment always turn into dementia? And the case is no. And do we know the exact, and we're learning more about the pathophysiology or what is underlying dementia, but we still don't know a lot about all that. So unfortunately, dementia is one of those more challenging areas of neurology where We still don't have a lot to offer patients. But the main thing I think that we can offer is that diagnosis, is that workup, and say, okay, is this cognitive impairment? Is this dementia? And what we do is we'll have, so if that's someone that, if you're concerned about yourself or somebody else, I highly recommend you make an appointment and you'll come to the office and we'll evaluate you. And I also recommend very highly that you bring someone along with you, because it's very important when we're talking about dementia, cognitive impairment, to get the opinions and the insight from somebody that's been around you, or when you're the one concerned for somebody else, to have that insight that you have, because sometimes people that have dementia aren't even aware of it. And so it becomes very important to be able to get multiple input from multiple people when we're evaluating for dementia. And what we do is we use different assessment tools that have been validated in terms of trying to establish if there is significant impairment in thinking and cognitive ability. And one of the ones that I use is the MoCA, but there's other ones that you can use as well. And so we'll take a thorough history when you come in. We'll do some of that kind of examination. Oftentimes, I'll have patients referred to what is called neuropsychological testing, where they get it's a full day of testing,
Yes.
And it really goes into all the different domains, because thinking and cognition is it's not just one thing. It's not just math. It's not just logic. It's not just language. And so what they do there is they really assess all the different domains, and you can get a really good look at where the problems lies, if there are any. And sometimes too, something that's very interesting and important to know is that dementia sometimes can actually be depression. And depression, if someone is depressed enough, especially as we get older, it can be a mimicker. And so neuropsychological testing can help with that as well, because then we determine, hey, you know what, the problem is actually a mood disorder. And then they're getting the right treatment, right? Because the last thing we want to do is diagnose someone with dementia when they're just depressed, and then they're not getting the help that they need. So it's very important, if this is something that you're considering or something you want to get evaluated for, you come in and we'll do extensive evaluations and try to get to the bottom of it. And sometimes I'll know based on the history and what we're finding, and actually more and more tests are coming out that can help with the diagnosis, such as for Alzheimer's, there's now biomarkers that we can get in the fluid, and we can also do some imaging that can help support a diagnosis one way or another. Sometimes it's more challenging and we don't have an answer, but we know something's going on. And then in that case, what we do is we follow over time, and we hopefully will come to a diagnosis with some time. And I think even if we don't have a lot of treatments, the benefit is the family's awareness, the patient's awareness, things that we can do to keep the patient safe, keep that person safe, and then things that have been shown to help slow disease progression. Some medications can help kind of with the memory impairment and Alzheimer's. Can you reverse the symptoms? No, but we can help kind of slow it down. And then those things that, again, it's as a doctor, you feel like you're always harping on this, but eating right, exercise, those help prevent dementia, and they help slow down disease progression. So even, when we're not talking about stroke, those are things that at the heart of, really are at the heart of being healthy, right? So,
well, we have a lot of patients that come in and say, well, I don't want to get dementia. And I say, well, I don't want to get dementia either. But it's helping them to understand that there are things that you can do in terms of preventative measures. Being healthy, watching your blood pressure, cholesterol, exercise, taking part in activities where your mind is active. We saw a tremendous example of that over the past 2 years, where patients were isolated. They were away from their families. They were away from their normal activities, their normal hobbies, card club, going on social excursions, all those types of things. And that caused significant cognitive decline in people that were otherwise not having any issues. Similarly, the depression aspect of things, where a lot of people who had never had problems with depression in their lifetime, over the course of the past few years, because of all of those factors associated with the isolation, developed more problems. One thing I know that we will have every day is patients that come in and say, hey, I forgot where I put my keys, I forgot so-and-so's name, and I forgot an appointment. Do I have dementia? Can you speak a little bit to what we consider normal memory-related things? Because if that's the case, I think I have dementia.
Yes, exactly. So that's funny that you say that, because I have a lot of that. I get a lot of that too. And it is, sometimes it's even for me, I'm like, oh my gosh, why, can't I remember this? Or, it's, but there is a certain level of, just human, and what I want to say is, what goes into memory is it's a complex process. Memory isn't just remembering things. That's what, you have to first have attention to whatever it is you want to remember, right? If you're not even paying attention, well, good luck remembering it, right? So is it that you don't remember where you left the keys? Is it because your memory is faulty, or because you weren't paying attention to where you left the keys, right? So right there, right at that very first step, you can have a problem. Then it's actual, memory consolidation, and then memory retrieval. And so if you have any problems along that pathway that maybe can be influencing that, then it may appear to be a memory problem, but it's not. And so the same with, coming back to depression, that's a big reason why depression seems to be, can appear to be cognitive impairment. It's because in depression, the mood disorder is affecting our attention. Mm-hmm. It's affecting our ability to retrieve, the way our brain is processing information and our ability to retrieve it. And so, again, it can look so much like it, and yet it's not. And so it's not really a problem of the brain. And so I think a lot of times people, and that's, again, if you're not in the medical field, it might not be something that you intuitively know. But I think a main thing, especially in this day and age where we have computers, phones, we're doing multitasking, we're driving and talking on the phone, everyone is so busy, we have so much stuff and so much stimulation that our attention is really getting affected to a very big degree. And so I think that that probably is where I see a lot of the problems stemming from. And yeah, it can be scary, but yeah, where you really start wondering, do I have dementia, is when you're having trouble, if you get lost in familiar places, if you're having trouble doing math that you used to be able to do, if you're forgetting people's names that you should know, right? You should always know your daughter's name or your son's name, I would hope, or your mom or dad. So if that starts becoming an issue, that's when you start getting concerned. If it's, someone you met 2 years ago and you saw them once and you can't remember their name, well, that's normal. I forget people's names even 10 minutes after I met them. It's horrible. I'll remember their face, but their name might be hard.
But those more complex tasks,
yes,
like you say,
exactly.
Math skills are frequently an early indicator. People who previously were cooks or chefs and had very complex things that they used to do, or hobbies that they did that were relatively complex that they have disengaged from. Some of those are kind of some of the early signs. So I think it's important, as you said, very early on to get a good diagnosis. And so that's one of the reasons we're so excited that you're here, is we can start that initial process and then lateral the football over to you, and thankfully you're there to take us the rest of the way home. Are there any other questions?
There aren't any more questions, but you mentioned Parkinson's, so I wanted to just bring up again that we do have a Parkinson's awareness event this Saturday. Our rehabilitation center is doing that, and we'll put the information in our comments too, but it'll be at First Baptist Church at 10 a.m., and it's just a time for Parkinson's patients to get together, learn more about the disease, the importance of the big exercise and therapy, and just receive some encouragement from others. So that'll be this Saturday.
Excellent. And we'll have that in our comment section, a little more information on that. I always have to put a plug in for Rocksteady Boxing, which is a program that we have here, which about 3 years, I think that's been going on. I had several patients who participated in that. Tremendous. And all of them going in were like, why am I going to do this? And within just a few sessions had tremendous improvement in their symptoms across the entire spectrum of Parkinsonian symptoms, which I think is the exciting thing about that program. Any other questions or thoughts?
No, not this time.
Very good. All right. Well, again, we're here today with Belén Lawless, and very excited to have you as part of the Good Samaritan family. When is it that you'll be starting as far as seeing patients in the office?
We are just waiting on some paperwork and so the DEA. I got my license, so we're waiting on some things. So right now, starting May 9th is what I heard, but if things come through, maybe earlier. So. But the earliest, right now, May 9th seems to be the first day for now.
Very good. Well, thank you very much for joining us, and thank you, everybody, for being with us today for Good Samaritan Facebook Live. We'll be with you again in the future. Thank you.
Thank you.